Yeah, just 1 second. Huh?
Okay, sir.
Okay, let's start.
Okay. So good morning all. Today our topic of presentation is peripheral retinal lesions which predispose to the retinal detachment. Okay. First we'll see some relevant anatomy of peripheral retina. First we'll look for the pars plana. Pars plana, it is a part of the ciliary body. Ciliary body, it's divided into the two parts. That's the pars placata and the pars plana. Pars placata is the anterior 2 millimeter area of the ciliary body, which has a where the it is attached to the zonules with the a finger-like projection, and the pars plana, it is a planar surface which is 4 mm, and it is posterior surface, posterior part of the ciliary body, which is 4 millimeter, and it starts ciliary body. It usually start 1 mm from the limbus and extend posteriorly up to the 6 millimeter. Okay, then we'll look for the ora serrata. Ora serrata, it's a junction between the retina and the ciliary body. Few of the important structure of the ora serrata, these are the dentate process, oral base, and the meridional folds. The dentate process, these are the tapering extension of the retina or the pars plana, and these are the more marked nasally as compared to the temporally. Here these are the all the dentate process. Oral base, these are the scalloped edges of the pars plana epithelium between the two dentate process. These are the oral base, and this is the closed oral base where the dentate process it closed the area of the pars plana. The next comes the meridional fold. This is the thickened retinal tissue which lines the in line with the dentate process, and at its apex there will be the retinal holes might be the present one. Then next one entity comes, that's the meridional complex. It is a complex which is formed with the dentate process and dentate process and the meridional fold which align the ciliary processes. Okay, this is the image which just summarize the all of the structure of the retina. Here is the posterior pole of the retina almost, and this is the macular area of 5.5 mm. These are the 4 vortex vein which gives the landmark for the equator, and beyond the equator there is a peripheral retina, and here all these are the ora serrata region where, and these are the dentate process. Here the nasally the dentate process which are more marked as compared to the temporally. Okay, next comes the vitreous base. Vitreous base, it is the just attachment of the vitreous base, and it's the one of the strongest attachment of the vitreous base, and it is almost a 3 to 4 mm wide zone which is straddling the ora serrata, throughout which the cortical vitreous it is strongly attached. Okay, so the following of the PVD, the posterior hyaloid face, which remains the attached to the vitreous base. So pre-existing retinal holes within attached vitreous base, it do not lead to the RD usually. Okay, now we'll look for the classification of the peripheral retinal degenerations. These are the vitreoretinal degeneration, intraretinal degenerations, and the chorioretinal degeneration. In vitreoretinal degenerations, it comes the lattice, snail-track, snowflake degeneration, and white without pressure. In intraretinal, it's a microcystoid degeneration, degenerative retinoschisis, pars plana cyst, and in chorioretinal, there is a paving stone degeneration. First we'll look for the lattice degeneration. The prevalence of lattice degeneration, it's almost up to 8% of the population, and it probably develop in early life with a peak incidence during the second and third decade is noted. Okay, so in pathology of the lattice degeneration, it's the lattice degeneration is actually the discontinuity of the internal limiting membrane with a variable atrophy of the underlying neurosensory retina. The vitreous overlying the area of the lattice is a syncytic, but the vitreous attachment around the margins, these are the exaggerated. The localized thinning of the inner retinal layer and the vitreous liquefaction overlying the thin retina with the vitreous condensation with exaggerated vitreoretinal attachment at the posterior margin, and the lateral horn of the lesion is noted. Next comes the sign of the lattice degeneration. We usually note the spindle-shaped area of the retinal thinning. It is commonly located between the equator and the posterior border of the vitreous base, and there will be few sclerosed vessels will be there. Here, the arrows which noted the sclerosed vessels, which forms the arborizing network of the line, and it's a characteristic. Okay, some of the lesion will also show the snowflake lesions, which is the remnant of the degenerated Muller cells, as well as there will be hyperplasia of the RPE is noted, and there will be the small holes noted along the lattice. Complications, no, most of the lattice will not lead to the complication, but the tear may develop the consequent to the posterior vitreous detachment when the lattice is sometimes visible over the flap of the tear. The atropic hole, the 2% which lead to the RD, and it's the risk in young myopes. Okay, the some of the indications for the treatment of the lattice. These are the lattice with a tractional hole or the break within it. The symptomatic lattice, that is the flashes and the floaters due to the vitreoretinal traction at the edge of the lattice. Then the retinal detachment in other eyes. Patients undergoing refractive procedures, lattice with the subclinical RD surrounding the subretinal fluid with a less than 1 disc diameter in size, even if the pigmented and the appear it's like an old one. And then the one-eyed patient, family history of RD is there. A typical lattice degeneration, that is the radial or the paravascular lattice, which is seen in hereditary vitreoretinal degeneration like the Stickler syndrome. And these are typical lattice degeneration. These are usually within the equator. Okay, so indications to observe the lattice, these are the asymptomatic lattice, the lattice with the no break or the holes, then the pigmented lattice with the no break or the hole, or the lattice with the atrophic holes. Okay, now treatment treatment of it is the barrage laser. The mechanism of action of barrage laser, we already know that it's generate the stiff chorioretinal adhesion surrounding the lattice. As well as it counters the vitreoretinal traction and prevents the fluid from vitreous to entering into the subretinal spaces. They usually we give the 3 rows of the confluent grade 2 to 3 burns covering all the margins of the break should be applied, and special attention should be paid to the anterior margin near the ora. Next comes the Snail-track degeneration. It is a glistening white band, frost-like area, elongated oval shaped, and it has multiple white dots within it. This is mostly seen in temporal quadrant. Majority are seen in at least 2 disc diameter anterior to the equator. Predominantly it's seen in myopes, and it is usually bilateral condition. The lesion, it resembles the lattice degeneration and can sometimes be noted as early lattice. Both may have the single or the multiple hole within it. The retinal thinning with the irregular borders, and there are usually no sclerosed vessels noted in Snail-track degeneration. Next comes the cystic retinal tuft. Actually, this is very rare condition and congenital lesion where the abnormal vitreoretinal adhesion causing the small breaks or the tear. Okay, it is located at the equatorial region or just anterior to the equatorial region with a pigmentation around it noted. It can be present in any quadrant, usually unilateral, and the pathology of it lies in outer retina and the RPE, which appears degenerative. The cystic retinal tuft may be avulsed by the vitreoretinal traction with or without posterior vitreous detachment, and it can lead to the horseshoe tear with irregular breaks. As it's a rare condition, so usually prophylactic treatment is not needed for it. Next comes the degenerative retinoschisis. Prevalence, degenerative retinoschisis is present in about the 5% of the population over the age of the 20 years, and most commonly prevalent in hypermetropia. Okay, pathology of degenerative retinoschisis. There are the develop the multiple microcystoid degenerations in the retina by the process of, and these microcystoid degeneration, they are going to get coalesced and resulting into formation of the separation of the splitting of the neurosensory retina into the inner and the outer layer at the outer plexiform layer, with a severing of the neuron and complete loss of the visual function of the affected areas. Symptoms. These patients, photopsia and floaters are usually absent because there is no vitreoretinal traction in this kind of lesion, as well as there is patient will rarely complain of visual field defect when there is a spread to the posterior to the equator. Symptoms are occasionally due to the vitreous hemorrhage or the progressive RD. 80% of these lesions are the bilateral one. Most commonly involved area is the inferior temporal area. Then elevation is usually convex, smooth, thin, and relatively immobile one. So how to differentiate it from the RD, long-standing rheumatogenious RDs? There is an absence of the demarcation line.
Voice is a little less
Uh,
clear.
uh,
Yeah, better. Yeah.
So demarcation line is usually absent in case of the degenerative retinoschisis, as well as on B scan there will be absence of the secondary cyst in case of the retinoschisis. Okay, so the usually the lesions it progress circumferentially uh, until it involves the entire periphery, and typically it usually remains anterior to the equator. But the reticular type of that the schisis, it usually spread to the involved to the macula. Usually the reticular schisis, it is a congenital type of the retinoschisis, where it most commonly involves the macular area, and so because of the involvement of the macular area, visual prognosis is poor, as well as as it's a congenital condition, it involves most commonly the first 2 decades of the life. So presence of the pigmented demarcation line is likely to indicate the presence of associated RD in case of the retinoschisis, and usually the breaks may be present in either one layer or both the layers usually present. Inner layers, these are usually small and the round, while the less common outer retinal layer, which is usually larger and rolled edges, these are located behind the equator. Complication, usually RD, which is the rare one, even in eyes with a break in both the layers, incidence is usually very less, that's 1%. The detachment is almost always asymptomatic and infrequently progressive and rarely requires the surgery. Posterior extension of the retinoschisis to involve the fovea is very rare, but it can occur, and progression is generally very slow. Vitreous hemorrhage is a rare one, but the one of the complication of it. Then management, small peripheral retinoschisis, it probably does not require the routine review, though the routine community optometric examination after 1 to 2 years may be prudent. The large retinoschisis should be observed periodically, particularly if the breaks are present in both the layer or it extend posterior to the equator. Then retinopexy or the surgical repair may be indicated for the relentless progression towards the fovea, when complications by the retinal detachment should be excluded. Some of the authorities also advocate for the prophylactic retinopexy of the posterior border of the large bullous retinoschisis with the subretinal breaks to prevent the progression to the symptomatic RD. Next comes the lesion, that's the white with pressure. Actually, it refers to the retinal area in which there is a translucent white gray appearance, and it can be induced by the scleral indentation, most commonly observed along the posterior border of islands of the lattice degeneration, Snail-track degeneration, and the outer layer of the acquired retinoschisis. It frequently seen in normal eyes and may be associated with abnormally strong attachment of the vitreous gel, though may not indicate the higher risk of the retinal break formation. And after this, we'll look for the white without pressure. Here the appearance of the white without pressure as like a white with pressure, but the presence that is, it is without the scleral indentation. White without pressure, it corresponds to the area of fairly strong adhesion of the condensed vitreous. It may be mistaken for the flat retinal holes. Giant ear, it usually develop along the posterior border of the white without pressure. For this reason, if white without pressure is found the fellow eye in patient with spontaneous giant retinal tear, prophylactic therapy should be considered for the white without pressure, and regular reviews should be considered for the treated and untreated eyes also, though the evidence of the benefit is of limited. So that's it, sir. Yes, sir, I finished with my presentation.
One moment. Okay. Yeah. Okay. So, can you summarize what are the lesions that you need to treat? For example, patient comes to you for either refractive surgery or say cataract procedure.
Yes, sir.
So you generally have to do a fundus examination
Yes,
before
sir.
operating. Yeah. So
Yes, sir.
can you
Sir,
list the lesions?
yes, sir. The lattice degeneration, we have to treat the lattice degeneration, which shows the breaks in it, as well as there is symptomatic lattice is there, which patient complaining of the flashes, floaters. Then snail-track degeneration along, it's also same. If the patient is complaining of any lesion, any symptoms, we have to treat it. Then along with that, out of these lesion, if the patients with the degenerative retinoschisis is there, we have to if there is a break for the both the layers is noted, then we have to treated the degenerative retinoschisis also. Then next, white without pressure, if white without pressure is there, then also we have to treat, we can treat white without pressure before the cataract surgery or any refractive procedures.
White without pressure. Where did you read that we have to treat?
Sir, actually, I just heard from some of the I didn't read it from the that for before the any refractive surgery or what, but usually I saw one of the surgeon, he did the white without pressure also, means before
Okay.
the.
So white without pressure is little, less understood entity.
Yes.
Can you show white without pressure, that slide that you have?
Yes, sir.
So white without pressure is basically what there is a strong adhesion of condensed vitreous, right?
Yes, sir.
Area. And the problem is that sometimes giant tears are associated with white without pressure. Okay.
Yes.
Generally, we treat this only if the fellow eye has a tear. Then only we treat.
Okay.
Okay. So generally, we don't treat it prophylactically because there is always a chance with white without pressure that laser may itself induce PVD and cause a tear.
Okay, sir.
So unless there is a strong predisposition, maybe a family history or the other eye has detachment, then we may treat.
Okay, sir.
Okay. Any other? So can you again lattice? So lattice, the most important thing to understand is the histopathology of lattice. Okay. So what does histopathology of lattice say?
Sir, actually, it's a discontinuity of the internal limiting membrane, and there is a variable atrophy of the underlying neurosensory retina, and as well as there is a sclerosed vessels usually will be there, and the vitreous overlying it is usually a liquefied vitreous. There might be the chances of uh, margin, it will just pull the posterior margin of it more commonly.
Yeah. So see,
Into the eye.
histopathologically, if you see the peripheral part, the hyaloid, posterior hyaloid, or the fibers in the peripheral vitreous, it is actually pathologically connected to inner layers of the retina.
Yes, sir.
Okay. So this is the common observation that vitreoretinal surgeons have, that when we induce PVD, even in a case where there is no detachment, say, and you have to induce PVD, for example, say macular hole is there and you are inducing PVD,
Hmm.
and suppose the patient has peripheral lattice degeneration. So
Hmm.
in that area, it's not possible to detach the vitreous completely from the lattice. If you try to do that, there will be horseshoe tear formation. That
Okay.
is because the vitreous itself is directly connected with the retinal layer. So what you can do just is to trim the vitreous over the lattice degeneration, but you cannot detach it from the area of lattice degeneration. Okay,
Okay.
so that's why the lattice degenerations have risk. Like whenever there is a PVD and patient has lattice degeneration, there is a possibility that horseshoe tears may develop.
Okay, sir.
In myopia, what is considered as high myopia or pathological myopia, where
Sir,
we may need to treat lesions?
sir, more than 6 diopter of the uh, optical correction, we usually consider it as a pathological myopia.
Axial
Uh,
length, because
as
the
well
see
as,
myopia can be because of corneal pathology also,
yes,
na?
sir,
So
as well as axial length is of more than 26 millimeter.
right, so axial length is also important. So whenever there is higher axial length, it is seen that there is a higher risk of detachment. So we generally treat any lesions which may predispose for detachment.
Yes, sir.
Right. Okay. There are some other lesions which are commonly mistaken. One common mistaken lesion and which is commoner is paving stone degeneration.
Okay.
You have not shown the photo of that, right?
Uh, sir, okay.
So, okay, fine. So, paving stone generally looks like, you must have seen the geographic atrophy of macula,
Okay, sir.
right? Where there is a RP completely degeneration.
Hmm.
So, paving stone looks similar to that in the periphery with pigmented edges. And unlike lattice, there are no crisscross, linings over that. It's just like a RP atrophy patch. And in fact, stone degeneration has no predisposition for detachment. In fact, it's like a protective factor. Like when you do cryo of the periphery, what the reaction afterwards, whatever sequelae we see is similar to paving stone degeneration. That is because that is the area where chorioretinal adhesions are quite strong.
Okay, sir.
Okay.
Hmm.
So when we do laser of a retina, what are the changes which are occurring? For example, say we do laser of the lattice degeneration,
Hmm.
then what are the changes which happen?
Sir, the strong attachment of the vitreous will be there at the posterior border. So with the help after we are doing the laser, this attachment is strong attachment is going to get released, as well as these lasers, it usually prevent the entering of the fluid into the subretinal spaces, and there will be the strong chorioretinal adhesions will formations will be there after the laser.
Yeah. So as you have mentioned here, the laser produces stronger chorioretinal adhesion, right?
Yes, sir.
The lesions which produce detachments or breaks are the lesions where there is strong vitreoretinal adhesion.
Yes, sir.
Okay, so by inducing a chorioretinal adhesion, what you do is you create a counter force against the vitreoretinal adhesion.
Yes,
Because
sir.
whatever is stronger, for example, say if vitreoretinal uh, forces or the adhesion is stronger, then it will tear the retina.
Hmm.
If chorioretinal adhesion is stronger, then what will happen? Vitreous will just detach from the that part.
Yes, sir.
Of course, this doesn't occur in lattice because, as I said, histopathologically, it's intermingled, that vitreous. Okay, so it cannot detach from the lattice completely. So in that case, you try to go as anterior as possible to the lattice while you are doing the demarcation, because the tear may extend anteriorly. So in that case, what the laser does is that it creates a barrier for the break to let the fluid inside.
Yes, sir.
Okay, so
Yeah.
for lattice also, apart from posterior 2-3 burns, try to cover as much as anterior margin as possible. Okay, that I think it is written like special attention should be paid to the anterior margin of the aura.
Yes, sir.
Correct. But that is because that is the area from where the fluid may pass.
Yes, sir.
Okay. So same is true with all other lesions also. And so you have to cover the anterior margin properly.
Yes, sir.
Okay.
Hmm.
Okay, good. Any other questions from other fellows residents? Any questions?
No, sir.
Okay, so should we conclude?
Yes, sir.
Yeah,
Thank you,
I
sir.
think retinoschisis is a rare thing, but I think one should be aware of that
Hmm.
and commonly mistaken as detachment. But you have already mentioned the differentiating points.
Yes, sir.
Yeah, okay. So ultrasound B scan. Also, in case of sometimes
Hmm.
uh, glaucoma workup also sometimes reveals defined scotomas in case of retinoschisis. I had seen one case where the patient was thought to have glaucoma
Yes.
and retina was not properly examined and patient in fact had a retinoschisis in that area causing scotoma.
Sir, I had a question.
Yeah.
Sir, suppose in the patient of macular hole and there is, as you mentioned, if there is any lattice degeneration in periphery, it's already lasered. Then while inducing PVD, do we trim the vitreous along the lattice first and then we induce it centrally, or is it the other way around?
No, basically see first you do core vitrectomy as usual,
Okay.
right? And after that you have to induce PVD because it's not possible to just trim the vitreous around easily without PVD
Okay.
because we have to trim it along the posterior margin also, and that will be easily available when there is a PVD.
Okay.
Okay.
Yes.
But the thing to remember is that when you are inducing PVD in the periphery, you should not be too aggressive around the areas of lattice. Otherwise, you will create breaks.
Okay, sir.
So go with the shave mode near that area and trim the vitreous.
Okay.
And maybe another approach, like whenever there is a case of macular hole or ERM, if you find peripheral lattice degenerations, I think it might be a good idea to just laser it pre-operatively itself. So that reduces one step during the surgery.
Okay, sir.
Okay. Okay. So let's then stop the meeting.